Hello, good morning. My name is Marcelo Shapira. I'm a geriatrician at Hospital Italiano de Buenos Aires, Argentina. It's a pleasure to be able to chair this session in what is probably the most important event of the year in geriatrics medicine. I want to introduce my friend, Dr. Gustavo Duque, a prestigious geriatrician. He has published multiple papers on bone aging, being a reference of the subset of osteosarcopenia. He's the head of internal medicine and the director of the Australian Institute of Musculoskeletal Sciences at the University of Melbourne and Western Health. Today, he will speak on the topic Geroscience approach to age-related musculoskeletal disease. Gustavo, thanks again for participating in this event, and we listen to you carefully.
Hello, everyone. It's a real pleasure to be here at the meeting of the International Association of Geriatrics and Gerontology. I would like to start by thanking the organizing committee for inviting me to talk on a topic that I think is becoming a very hot one, not only in the gerontology, but also in the geriatrics field. What I'm going to do today is divide every part of my talk in three sections. One will be the description and analysis of the biological mechanisms that explains each one of the components of the geroscience and what we call the pillars of aging. Then the second part will be focusing on diagnostic and potential mechanisms that we can use to identify these alterations associated with aging in the musculoskeletal system. And then we will have a third component, which will be the potential therapeutic approaches. So let's start by defining geroscience. For those of you who are not familiar with the concept, I would like to start by sharing this definition that Brian Kennedy proposed a while ago in 2014, and that has been widely accepted in a way that now we understand gerosciences as these shared mechanisms, shared biological mechanisms that drive aging, but at the same time explain the pathophysiology of several age-related diseases. Before, we used to think that every age-related disease, every chronic disease had their own pathophysiology and their own mechanisms. Now we understand that is not the case. Now we know that thanks to the new findings about geroscience, we know that some of these mechanisms are shared by several age-related diseases. So you see here in the figure, you see these components of aging biology, which we are going to start from now and through all my talk, referring them as the pillars of aging. We can connect all of them and through them explain the pathophysiology of several of the diseases that are shown in the right side of the slide. So you see here a long list of diseases that are highly prevalent in older people. And I would like to focus today in two of these conditions, which are very much connected and very relevant in terms of the geriatrics clinical practice. One of them, sarcopenia of age-related pathological magnitude of age-related muscle mass loss and loss of muscle mass and function. And we're going to talk about osteoporosis, which is associated with bone loss. And this is important, again, coming back to the definition by Dr. Kennedy, because this new understanding of the shared biological mechanisms also provides diagnostic and therapeutic opportunities that we didn't have in the past, and that as now we are using them to develop new therapies that could be or could have a combined approach, combined therapeutic effect to several chronic conditions. But here we have to make a differentiation, and this is also important, a differentiation between what happens in normal aging or what happens in pathological aging. When we cross that border between what is expected to happen in our organs and systems or versus what we can define as a disease. And here is an example. This is evidence obtained by our postdoctoral fellow at the University of Melbourne and AIMS, Dr. Benkirk, who performed the Australian body composition study with 15,000 adults aged between 18 and 88 years, where we define, our team defined and identified the reference range for normal body composition, and that included the muscle loss that we observe in both men and women throughout the normal aging process. These were healthy individuals which we consider as having normal age-related muscle loss. Now, other group here in Australia, from Julie Pascoe at the Geelong Osteoporosis study with about 1,500 older adults, from 20 to 97-year-old. They identified the reference range for normal bone loss that we observe with aging. So you can see here how we have different patterns in the femoral neck and the total hip, but at the same time, we can observe that progressive decline. So we have here a normal aging process in the muscle and bone. And at the same time, and this is also a very interesting finding that we are now understanding much better, is that at the same time that we lose muscle and bone with aging, we also observe an increase in the fat infiltration that we observe in these two organs, in the muscle and bone. We can see how fat infiltrates the bone marrow and how fat infiltrates the muscle. This is clear data from the UK Biobank in more than 9,000 aged volunteers, 45 to 80, where we can see that the fat infiltration increases with aging. But again, this is an observation in normal conditions, normal healthy volunteers. However, there is a special subgroup of people who develop exaggerated, who go the bone and muscle loss that go beyond what we consider a normal aging process. And that's where we start labeling them. Once they cross that borderline for normality, then we can consider that they have a disease. And if somebody has at the same time bone and muscle loss that goes beyond the normal expected reference range for their age and gender, then we can start considering that these normal curves, when they become exaggerated, they cross into the pathology and they develop what we are calling now as osteosarcopenia, which is a concomitant occurrence of osteoporosis, osteopenia, or sarcopenia in the same subject. What is interesting here, you look at the top of the slide here, you can see that we have a few risk factors, what we call risk factors. So people who have these kind of risk factors develop one or several of them will develop or will cross that border into disease. So they will become osteoporotic, osteopenic, or sarcopenic. And that's relevant because we have here factors that we know are shared between these two conditions. So that includes physical inactivity, low vitamin D and calcium, corticosteroid use, aging, as I already mentioned, inflammation, hormone imbalance. So you see, you look at all these different factors, these risk factors or these conditions are explained in most of the cases by alterations associated with abnormal aging or pathological aging or unhealthy aging. What happened at the end, and this is the relevance for us as clinicians, is that if somebody has osteoporosis, we know, or osteopenia, we know they are at higher risk of fractures. And if somebody has sarcopenia, we know that they are also high risk of disability or metabolic alterations, and of course, a higher risk of falls. At the end, what we want to do is first to prevent the development of these or the presence of these risk factors, modify these mechanisms, and then prevent the appearance of these two conditions. How do we do that? Well, first we have to understand very well the mechanisms and the biological mechanisms that explain or explain all these changes in order to have or to develop strategic therapies, strategic interventions that could maybe, if we apply the geroscience concept, maybe we can affect and modify several of these factors at the same time. With this, and again with our postdoc Ben Kirk, we proposed a while ago that osteosarcopenia, if we look at all these risk factors, osteosarcopenia is basically the consequence of alterations in the pillars of aging that I showed at the beginning, the pillars of aging that are associated also with the mechanisms and the shared mechanisms of chronic diseases. In this case, the shared mechanisms of osteoporosis and sarcopenia or osteosarcopenia. And you can see here, I'm sure some of you in the audience are familiar with or working with in research or clinical practice with one or several of these components: metabolic alterations, macromolecular damage, epigenetics, inflammation, adaptation to stress or alterations in adaptation to stress, alterations in proteostasis, and stem cell affected stem cell and tissue regeneration. You look at these components, one or several of them will explain what we observe in exaggerated in pathological bone and muscle loss, or what we observe in osteosarcopenia. So now I invite you to join me in this analysis and of the evidence that we have at this moment about the role that each one of these components may have in the pathogenesis and potential treatment and therapeutic interventions for osteosarcopenia. So let's start with the first one, with this, the proteostasis. This is important because when we have the concept of proteostasis is that when the proteins are produced, I mean, we need a good level of proteins to produce all our organs and tissues. Very important to produce our bone matrix and our healthy bones. We also need a good level of proteins to produce muscle, of course. So what happens when we have normal proteostasis and we have these proteins that are active, the proteasome is active, the proteins are well produced, are healthy. There is also what we call protein, I will not go into all this concept, but protein polyubiquination. And very importantly, we produce these proteins, our cells produce the protein, and at the same time, as any metabolic or in any biological process, we produce garbage. The cells start producing garbage. We profit from the good proteins. We build up the proteins in the bone and muscle, but we also generate garbage. And you see here on the right side and on the left side, and this is the example of muscle, you see that we have here the concept of autophagy. Autophagy is basically a way to clean up what is left over after the cells have finished producing their normal proteins. What is the problem here, and is related with aging and specifically with unhealthy aging, is that we lose that capacity of normal proteostasis, in which we don't have, we affect most of the components of the proteostasis. As you can see here, all these different components are affected. Now, that's the left side is showing the changes in the muscle. Look on the right side, and you will see that in the bone, it happens almost identically with this problem of proteostasis. We always we observe in osteoporotic bone or bones that have multiple abnormalities in the cell metabolism. We observe also alterations in oxidation, oxidative stress, which affects proteogenesis and proteostasis. I already mentioned about autophagy. And interestingly, when we observe this autophagy affected, we also observe that it affects, if the cells cannot produce the right proteins, if the cells cannot produce, cannot generate normal tissue, basically they will produce abnormal proteins, a lot of garbage. And imagine if we cannot clean it up, if we don't have a normal process of autophagy, what is going to happen? All that garbage accumulates in the cytoplasm, and sooner or later is going to affect cell function, and importantly will induce cell death, will affect cell survival. And that's where we see apoptosis and other mechanisms that we know are present not only in muscle, but also in bone affected by osteopenia and by sarcopenia. You see here that the cells at the end are different. Of course, we don't have the same cell types in muscle and bone, but one of the important cells that are affected in this process is here, the bone marrow stromal cells in the case of bone, but also the stem cells precursors in the muscle. If they don't produce the right proteins, they are not going to be able to generate new bone and new muscle. Then our capacity to regenerate it is affected, and we are at the same time going to produce a significant amount of garbage that, as I say, if there is no autophagy, we're not going to clean it up. So here we have very similar things happening both in muscle and bone from the proteostasis point of view. And that allows us to suggest that maybe we can target this process, improve it, and prevent bone and muscle loss. Our team did some experiments in terms of targeting this proteostasis, and particularly trying to prevent autophagy through some important regulators of this process, in this case, mTOR regulators. I will not go into all the details of the biology of it, but I can tell you that basically what we observe, and you can see here very quickly in the fluorescence images, is that when we use rapamycin, which is a regulator of this and an important regulator of autophagy, we could observe that we rescue osteoblasts, bone-forming cells, from dying, and we rescue them from having dysfunctional autophagy. So we basically help them to collect that garbage and discharge it without affecting their function. In this case, these cells were treated with fat, with a fatty acid, palmitate, which is very toxic. And we can observe that when the cells were treated with palmitate, autophagy and proteostasis were significantly affected. This is similar to what we observe in vivo in humans, because this fat affects function, as I'm going to mention later on. And here, basically, we target this process to prevent the generation of autophagy and alterations in proteostasis. At this moment, several clinical trials, very recent evidence has shown how rapamycin and what we call rapamimetics, compounds that act similarly to rapamycin, also have this potential to protect musculoskeletal tissues from showing these alterations in proteostasis and autophagy. So it's still an early phase, but I think that there is a very promissory understanding of the role of these regulators of autophagy and proteostasis, and also specifically going and targeting in the appropriate pathways that regulate these processes. Now, we also know that there are the other pillar of aging that I mentioned before, which is epigenetics. And this is also very interesting because in healthy, very young individuals, we have this very efficient way of performing DNA methylation. We have control of all of the chromatin. So of course, we need these cells to be in constant growth and turnover. And we see that muscle and bone are very active tissues. So we need that these cells express or develop a normal function in terms of DNA methylation and normal, basically to maintain a normal chromatin state. Unfortunately, with aging, and most significantly in abnormal or pathological aging, or when we see people with osteosarcopenia, and this is shared both in muscle and bone, we observe how these individuals have abnormal chromatin state. They cannot function the same. The histone is altered, and the DNA shows mutations that predisposes to more chronic diseases, to more less efficient bone and muscle turnover, and at the same time will predispose in some cases to neoplasms. In this case, for instance, we know that we can have at this moment we don't have an intervention that or a pharmaceutical, I will say, approach to this There have been lots of investigation and lots of experiments looking at how we can regulate this, how can we optimize DNA mutations, and how can we prevent this presence of abnormal chromatin states in people with osteosarcopenia, with musculoskeletal diseases. But we know also that we can manipulate the genes actually with two interventions that we as clinicians recommend widely. This is a summary that we published recently in terms of non-pharmacological approaches to osteosarcopenia. And there are two components that we know can, if we have appropriate protein supplementation, if we have appropriate nutrition, and we have active exercise, particularly in people who have already been affected by osteosarcopenia, we know that this combination of resistance exercise, balanced exercise, and nutrition, particularly nutrition, protein supplementation, and vitamin D supplementation, we know that it has a beneficial impact on these tissues. And at the same time, we observe how these epigenetic alterations could be reverted through this relatively simple intervention. Nevertheless, as I mentioned before, some of our colleagues are already working on developing interventions that directly will target these epigenetics abnormalities, trying to revert these changes and probably increase our lifespan and also have a regulatory impact on muscle and bone specifically. Now we move on to the next one, and this I classified as an inflammatory change when we go back to the pillars of aging, but it has also several implications in terms of regulating or affecting stem cells, affecting metabolism, affecting proteostasis. And I'm referring to the fat infiltration of muscle and bone. We can observe in the left side how a sarcopenic muscle is significantly infiltrated by fat. You can see how the fat doesn't only infiltrate around the fibers, but also inside the fibers. And it's very similar to what we observe, and you can see here in the right side of the slide, what happens with an osteoporotic bone. So we can see here how the bone marrow is infiltrated by fat, muscle is infiltrated by fat. This happens very significantly in older patients with osteosarcopenia. And we will observe what happens with these conditions and what specifically happens in the bone and muscle. We can here conclude that what happens when fat infiltrates the muscle, or when fat infiltrates the bone, the mechanisms, the alterations that we observe in the cells are very similar. And just to summarize it very quickly, we know that when bone is infiltrated by fat, we have a decrease in bone formation, we have a significant destruction of the bone. And at the same time, when muscle is infiltrated by fat, there are not only alterations in the anabolic properties of the bone or the muscle, but also we observe metabolic alterations. And you can see here also some inflammatory changes. And that's why I classify this into the inflammation component of the geroscience approach, because we also see alterations that could be described as inflammatory in bone as well. One of them very significant, which is the increased level of osteoclastogenesis. I already mentioned about the dysfunctional autophagy. So we can see the similarities. One mechanism that affects two tissues, an age-related mechanism that affects both tissues. And this, for the clinicians, this has clinical implications. We know that if fat infiltrates muscle and if fat infiltrates bone at the same time, there is a significant occurrence not only of osteosarcopenia. This is data from the AMBER study from Canada with 312 postmenopausal women, and where we found, or where they found, sorry, that these larger amounts of fat infiltrating the muscle and the bone affected the quality of these tissues and were increasing the risk of fractures in this population. So what we observe from the very biological principle into the pathophysiology, and we convert it into real clinical applications, we can see here how this infiltration affects both tissues and at the same time has an impact on clinical risk of these patients to suffer falls and fractures. This also allows us to target, to propose that we can target this fat. We cannot target necessarily all the other fat, and here we are talking about a very specific type of fat that infiltrates the muscle and the bone. It's not the same fat that infiltrates the viscera. It's not the same fat that infiltrates the subcutaneous tissue. This is fat that is not necessarily associated with obesity, but it's a very toxic fat. I hope you remember when I mentioned before about the palmitic acid, a very toxic fatty acid that is very prevalent in this fat. Well, this palmitic acid affects the function of, as we observe in our experiments in osteoblasts, affects other experiments have shown that it affects also the myoblasts, the muscle cells. So why not to target the production of this fatty acid by this specific fat? So we tested this hypothesis, and this is very preliminary data in mice, where we treated them with an inhibitor of fatty acid synthase. So these animals, were unable to produce palmitate because they didn't have the fatty acid synthase. They lost weight, but at the same time, and the compound that we use is called cerulenin, which is a very weak antibiotic, but it has a very strong effect on fatty acid synthase. When we inhibited the fatty acid synthase, what we observed first in bone, we observed that in oophorectomized mice, so in mice that we simulated the lack of estrogens that affect bone and induce osteopenia in these animals, we observed that when we treated them with fatty acid inhibitors of fatty acid synthase, in this case cerulenin, we were able to increase bone mass and recover these animals from osteopenia back into normal bone mass. But very interestingly, at the same time, we observed that treatment with cerulenin improved their muscle mass. And we also observed that this treatment improved muscle function. Overall, the summary of this evidence, is that we can target this fat. So I already mentioned before how we can target epigenetics, how we can target proteostasis, and here we can discuss on how we can target this share mechanism between osteoporosis and sarcopenia, how we can, through just targeting one mechanism, we can have a beneficial impact on both muscle and bone. Whether we can translate this into human studies is still pending. I think we still need a lot of evidence to move that far in the approach to targeting bone and muscle fat. But still, we think that as a proof of principle, as an understanding of geroscience approach to this mechanism, has a very valid evidence. Now let's move on to the stem cell and regeneration. This is important from the point of view that mesenchymal stem cells are the precursors of several of the cells we are talking about here. So we know the mesenchymal stem cells are precursors for muscle cells. We know that they are precursors for osteoblasts. So muscle cells, muscle precursors, osteoblasts, which are the bone-forming cells, even chondrocytes, and at the same time, they can differentiate in abnormal conditions, they can differentiate into adipocytes. So here, what are we going to do is we're going to analyze these changes that we observe in mesenchymal stem cells. So definitely, we already mentioned several changes that happen in mesenchymal stem cells affected by these alterations in proteostasis, epigenetics, even the fat infiltration. And now we consider them as a group of cells that with aging and as a share mechanism for osteoporosis and sarcopenia, we have these alterations and changes not only in their population numbers, but also in their capacity to become confluent or the capacity to produce new muscle or new bone. And for this, I just want to go very quickly on something that we have dedicated our analysis in the recent years, is what we call the circulating osteoprogenitor or COP cells. These are specific cells that have very high level of stemness, which means that they are stem cells that are in our circulation. And we have dedicated a lot of our efforts to understand who they are, what they do, particularly in the context of osteosarcopenia and frailty. What we have found, which is very interesting, is that in primary osteoporosis, we've observed that there is an increase in COP numbers. But at the same time, in secondary osteoporosis, and most importantly, in osteosarcopenia and frailty, we observe that these cells, the percentage of these cells in our circulation goes down. And at the same time, we have looked in human studies, where all these studies have been actually in humans, where we confirm that subjects with osteosarcopenia have much lower percentages of COP cells. When we then conclude that if this is a summary of all the evidence that has been generated by ours and other groups, we were able to measure COP cells in the circulation and determine the normal reference range. So I referred you back to what we did with the body composition, where we identified the reference range for normal, healthy individuals. Here we have this range, but then there is evidence. There is enough evidence in the literature to demonstrate by our team and others that, for instance, and this is the upper part is a summary of what groups like the one from Bob Pignolo in Philadelphia has been, and now at the Mayo Clinic, were able to demonstrate that if we have too many COP cells, so these are stem cells that are in our circulation, we have too many, then we could have, these individuals have what we call heterotopic ossification, so bone forms where it shouldn't be. Or they have aortic calcification. They are also observed in fracture healing. So it seems that these cells are in the circulation because they want to go to the fracture and help to heal the fracture. Whereas our group has demonstrated and has reported that if we have low levels of COP cells, then we observe a higher prevalence of osteosarcopenia and frailty. These are associations, these are descriptive analysis, so we still need some level of prospective longitudinal analysis to demonstrate what happened when there are changes in progressive or longitudinal changes in the number of COP cells. Nevertheless, and coming back to the different components that I wanted to share with you, there is a potential therapeutic element for COP cells. At this moment, we know from several studies, particularly from Florida, where older patients with frailty have been treated with stem cells obtained from bone marrow. And there have been allogenic infusion of stem cells have shown in phase 2 studies have shown that they are effective in improving older persons with frailty. This is phase 2 studies. In this case, we are proposing something a little bit different. We developed the technique to isolate and replicate and expand COP cells. If you think about how can we compare cells obtained from the bone marrow versus these cells, well, these cells are very easy to collect because we can take them from buffet coats, from blood banks, just peripheral circulation. So we have a young donor, we collect the COP cells, we isolate them, we expand them, and at this moment we are trying to reinfuse them in an older person with osteosarcopenia or frailty. And this is something that, again, it has very promissory evidence, at the same time that we can demonstrate by replacing these stem cells in people with osteosarcopenia, again, by targeting one mechanism, one geroscience mechanism, we're having a dual beneficial impact on both conditions, and maybe in other conditions, we don't know yet. And finally, we should not forget about that there is always this biomechanical connection between the muscle and bone. We cannot forget that when people are active, when we do exercise, these mechanical interactions are essential. However, when these interactions become abnormal, we have clinical significant also that affects muscle and bone. And this could be what we call the crosstalk, the different association between alterations, for instance, in muscle. And here we observe how muscle that in sedentary people with low levels of high levels of myostatin. Myostatin is a factor that is secreted by the muscle that affects the muscle growth. and that is called myostatin. And we know that, and this is a large study that showed that people with high levels of myostatin, serum levels of myostatin, also have low body mass and low BMD. This is very, very interesting because we know at this moment that there are several compounds that are being tested as inhibitors of myostatin. So maybe they will have a dual impact on muscle and bone. All this again is related to biomechanics, and we know that if somebody is exercises, is active, the levels of myostatin will go down, but for any reason that we cannot mobilize the same, or for other pathological conditions, we have higher levels of myostatin. Sclerostin is the other side of the story. Sclerostin is produced in the bone by the osteocytes, and it goes to the circulation and probably reaches the muscle. What we know is that if these sclerostin levels are high, they have been associated, this small study from Korea, but they have been associated with low muscle mass. So it's the other side of the story, a factor that is produced by bone that may have a different impact on muscle. The rank ligand, this is another interesting factor that is produced by the bone, affects bone resorption, induces actually bone resorption. We know that rank ligand now goes to the muscle and could affect the muscle breakdown, affects the muscle synthesis, induces muscle breakdown, and affects muscle function and mass. So these are examples that are triggered not only by the biomechanical impact, the biomechanical connection between muscle and bone, but also by this biological crosstalk that we are still trying to understand. This is a study by Ben Kirk again, where we looked at the CTX, which is a marker of bone resorption, and we were able to connect the high levels of CTX with poor muscle function. So all this is interesting because it's just to illustrate how these different factors that could have an important impact on bone or muscle metabolism locally could have a deleterious impact on the other tissue. And if we target some of them, maybe, for instance, if we target rank ligand or we target myostatin, then we will be able to have a dual beneficial impact on muscle and bone. And finally, please don't forget about the hormones. This is probably a component of metabolism, but also a component that involves or is associated with multiple of these changes that I already mentioned before. This list of hormones, most of them play a role not only in muscle formation, but also on bone formation. So please don't forget that when we have alterations in these hormones, we don't only focus on one tissue, we focus on those tissues that are affected at the same time, and our target will be to improve them from the perspective of improving or normalizing the levels of these hormones. Unfortunately, the evidence has not been very positive in terms of improving, for instance, in testosterone administration, we observe relatively levels of positive levels of increase in muscle and bone mass, but we don't observe effective therapeutic impact on anti-fracture or anti-fall efficacy. There's some controversy about vitamin D, the same story. It has some impact on muscle and bone, but we don't think that is as effective as anti-fracture or anti-fall efficacy as other interventions are, and we can go on with other of these hormones. So finally, to conclude, we try to, in this particular approach, we try to understand all the pillars of aging to also understand the shared mechanisms between osteoporosis and sarcopenia and maybe other musculoskeletal diseases. If we try to approach, and I try to summarize not only the biological evidence, but also the potential diagnostic and therapeutic approach, in some sense of what we call translational geroscience, in a way that we can understand the biological mechanisms that are shared by these conditions, and we can target them. Because at the end, what we want is first, our patients to have a healthy aging, to have a very nice quality of life, and remain independent, and at the same time prevent adverse outcomes such as fractures, falls, disability, or frailty. If that's the case, then I invite you to, when we decide to develop interventions for our patients, think that we are targeting several biological mechanisms, and just please keep having a look at this very exciting field, because the future has no limits in terms of our potential to identify these kind of interventions with multiple targets that will have also a very important impact on the reduction of adverse outcomes in our older population. With this, I would like to thank our collaborators around the world, and again, the organizers for inviting me, and I will be more than happy to join the session in person and in real life. I would say not in person, but in real life online, and answer your questions. In the meantime, thank you very much for your attention. Thank you.
Hi, Gustavo. Hi, it's very nice meeting you again. It was a great your presentation. How are you first?
Very well, thank you, Marcelo. It was very nice to see you, and thank again to the organizing committee for inviting me. It's a pleasure to be here. It's a pleasure to talk at this important meeting.
Okay. Now I have a question from Dr. Castrejón Pérez Roberto. He said, hi, Dr. Duque. I want to ask if any muscle group is considered to age differently. Is now straightened muscle experiencing sarcopenia all well? Thank you so much.
That's actually a very good question, because we know that skeletal muscle definitely ages at a different pace than, let's say, diaphragm. But at the same time, we observe that in people with sarcopenia, for instance, there is also a deterioration on the diaphragm function, which is very interesting, because we expect that the diaphragm muscle is totally different than, is completely autonomous, but we observe also changes in even including a proteostasis, as I mentioned before, or a fat infiltration. And there are several studies looking at, for instance, people with sarcopenia who get intubated, people who are admitted into intensive care. They are intubated, and after they intubated, the muscles, the diaphragm becomes deteriorated, and their function deteriorates as well. So it's interesting to see how all of them deteriorate at different pace, but at the same time we observe the same phenomenon, the same type of mechanisms, all associated with what we call as geroscience.
Okay. Now there's a question from Argentina. Dr. Yuri Jorge is in patients with dementia. What's your opinion? Do you have regarding subacute inflammation and its association with osteosarcopenia? Is there a relationship between both topics?
Well, this is a very, very good question, and the short answer is yes. We have done studies in people with cognitive impairment, and we have observed that when we do the mapping of the changes in the brain, we can tell that people with changes in specific areas of the brain are more affected in terms of muscle function, and also, and this is more interesting, muscle strength and muscle structure. We also know that people with dementia have a high risk of suffering or having osteoporosis. What is the mechanism? We don't think really that this is an inflammatory mechanism that connect Alzheimer's or cognitive deterioration, cognitive impairment, and osteosarcopenia. We think that there is also a neuromuscular, neurobone, I will call it, mechanism in which we lost this kind of neurotransmitters that are stimulating the differentiation of muscle and bone cells. What happens in Alzheimer's and in general in cognitive impairment is that all these kind of stimulating factors that are released by the neurological presence in muscle and bone are lost. Therefore, the muscle and bone are unable to respond to the signals that come from the brain. At the same time, and this is probably a confusing factor, is that, as you know, people with cognitive impairment are less mobile. So they spend more time in their chair. They don't mobilize as much as cognitively normal people. So that's definitely associated with osteosarcopenia, with muscle and bone loss. And finally, there is a nutritional component. People with dementia and cognitive impairment, they eat less. Their diet is different. And at the same time, because the diet is different, particularly the protein components of the diet are reduced, and they end up affecting their bone and muscle formation. So it's not just an exclusive mechanism. I don't think it's necessarily inflammatory. I will say that it's a combination of the factors that I already mentioned.
Okay, thank you very much. There is another question from Campo Verde, Evelyn. He says, hello, thanks for sharing. Are strength exercises contraindicated at any stage of osteosarcopenia?
No, I don't think so. I think exercise is beneficial at every stage of life, not only in people with osteosarcopenia, but in every person with any kind of condition. What is important is to determine what type of exercise is safe and what type of exercise has an impact on both tissues. And that's something that I would like to highlight here, is that there is a group of people a group of investigators who are developing interventions to improve bone mass, and there is a group of investigators who are developing interventions to improve muscle mass. What we need at this moment, when we understand that osteosarcopenia is a combination of muscle and bone loss, is that if we want to intervene on both tissues, we should develop protocols that have an impact both on muscle and bone. We cannot just isolate it in a fragmented way, because that makes also some confusion with our patients. If we send our osteosarcopenic patients just to perform exercise for muscles, then we lose the benefit that the exercise may have on bone and vice versa. So I think that what we need at this moment are protocols that clearly have an impact on both, on muscle and bone. There are some groups who are starting to work on it. We actually wrote guidelines with Mark Izquierdo from Spain. We wrote a set of guidelines in the Journal of Nutrition, Health and Aging, recommending exercises that may have or have an impact on both muscle and bone. So definitely there is not an age, there is not stage when you cannot do exercise. Of course, the exercise has some kind of implications in terms of risk, but at the same time, the benefits overpass that risk. And I think that as long as we use that exercise to improve bone and muscle mass together, then we will have a much more beneficial effect.
Okay, thank you. And now there is a question from Julio Nemirovsky. Okay, Dr. Duque, as always, thank you very much for your excellent presentation. I agree, of course. I saw that you included creatine among the nutritional intervention in sarcopenia. We have been discouraging if it for the elderly for a long time. Is there a new evidence for its use?
Well, very nice to hear from Julio, and hello, Julio. It's nice to hear from you. Yes, there is actually very, very interesting new evidence. This evidence has been summarized by Darren Carroll from Regina, University of Regina in Canada. And he has published, and we published one of the recent reviews with him in terms of the effect of creatine on muscle and bone. He actually published a couple of interesting clinical trials on or demonstrating the effect of this on both muscle and bone mass. Something that happens with this kind of protein supplement or this kind of supplements is that most of the evidence comes from healthy older persons. So rarely we see interventions like this kind of nutritional interventions in osteosarcopenic, very frail older persons. And I don't think there are many studies on that. First, because they are difficult to recruit. And second, because the effect on bone and muscle is difficult to measure. But I think that the studies and the work that they have done in Regina is very valuable and is very solid in terms of demonstrating an impact on improving muscle and bone function and mass. please keep in mind that these interventions have not demonstrated to prevent falls or fractures. Because nobody will do these kind of studies. They will require a very large sample size, which is something that we cannot do at this moment. But overall, I think creatine is now becoming part of the group of interventions that we can tell has a dual impact on bone and muscle mass and function.
Okay. Now it's a question from Carlos Molina. Congratulations, Gustavo. Bueno, what role do you give to strength and resistance exercises over multi-components, and what role do you give to anticatabolics such as HMB?
Well, I will divide that question into two. I will say the first one is definitely there are protocols, and as I mentioned, we published a set of recommendations in the recently with Mikel Izquierdo in terms of the Journal of Nutrition, Health and Aging, and regarding what we recommend in terms of strength and balance exercise. We think that the best way to do it is first progressive resistance, increasing resistance, and also stressing balance. And the other important component, increasing resistance is effective in a way that we change the direction of the exercises. If we don't change the direction of exercises, this is still effective for muscle, but it's not effective for bone, because the bone structure is very complex. It goes in different directions. The muscles usually go the same direction, but bones are in different directions. So you look at bone, they go in different, the trabeculae go in different directions. So you perform the same exercise with the same direction, the same strength exercise, you are going to benefit one set of trabeculae, but the other one will not respond. So, the main recommendation is if we want to impact on bone and muscle together, then we should expose the patients to exercises, strength exercises that goes in different directions. So jumping from one side to the other, then from left to right, front to back, and always associated with the balance exercises. The minimum duration has to be 30 minutes, and the minimum frequency is twice a week. And in order to see an effect, we actually published the meta-analysis in that area, is that it has to be for at least 6 months duration in order to improve muscle and bone. For the second part of the question, sorry, HMB is definitely an important component or an important supplement that has demonstrated many biological benefits on muscle. We don't know that much in bone, but very important benefits on muscle, not only in osteosarcopenic patients, but also in frail older individuals. Whether HMB has an impact on bone structure or bone mass, we don't know yet. This is a study that actually we're running at this moment, where our postdoc, Ben Kirk, who I cited in my presentation, is running a study. It's called the EMPOWER study, where we're testing the effect of HMB on both muscle and bone. So hopefully by the next meeting of the IAGG in 4 years, if we're still around, we will be able to answer that question.
Okay, thank you very much. Gustavo, what do you recommend to reduce the risk of osteosarcopenia in primary care? And the second part of the question, we have to work together with nutritionists, with physiotherapists, or only I'm alone with the patient in the consult?
Well, one of the things, I think the most important message here regarding osteosarcopenia in primary care is to increase awareness. Our primary care physicians, including geriatricians, are not very much aware, and we know that. We have the evidence to demonstrate that a lot of our colleagues are not aware of the existence or understanding of osteosarcopenia. A lot of us, regarding primary care, but also geriatricians, we understand osteoporosis relatively well. Despite that we understand it, a lot of people don't treat osteoporosis. So when we think about sarcopenia, the picture is even worse. a lot of our colleagues don't consider sarcopenia a disease. A lot of our colleagues don't identify sarcopenia in primary practice. So, Marcelo, my first consideration is that we should identify sarcopenia in primary practice if we want to start doing something about it. Some people say, okay, how am I going in my practice, how am I going to identify osteosarcopenia? Very easy. Osteoporosis, osteopenia, easy to identify. You use the criteria from bone mineral density. You identify those patients who have bone mineral density below -1 standard deviation, easy. With sarcopenia, it's a different story. At this moment, we have the American definition, we have the European definition, but my recommendation to my colleagues is stick with one definition. If you like the one from America, which only involves grip strength and gait velocity, stick to that one and identify your patients in your practice as sarcopenic using those criteria. If you prefer the European one, go ahead, order DEXA scans, but at the same time, if you are going to identify, my suggestion is try to do something about it. So again, coming back to your question, Marcelo, about the primary prevention and primary care, one of the things is to prevent it. Of course, preventive medicine is important. In geriatrics, unfortunately, we don't have the chance to do a lot of preventive medicine. We go into the secondary prevention. But if you have the opportunity to prevent it, then it involves appropriate nutrition, appropriate physical activity, calcium intake, and also the identification of the risk factor. This is something that is important in a way that now we understand that osteoporosis, osteopenia, and sarcopenia have exactly the same risk factors. Exactly the same. So we are sending our patients to our falls clinic at one side of the Italian hospital and then to the osteoporosis clinic at the other side of the Italian hospital to give you an example where they can be together and come to the same assessment for the same risk factors. This doesn't make sense. And I'm giving the Italian, but that's just to give you a generic example, but it could be a any hospital. So if we want to do primary prevention, the first thing is to understand and identify it, establish preventive measures. And if we cannot prevent it and the disease already developed, then establish interventions that have a dual impact for both muscle and bone.
Okay, thank you very much. Now, there is a question from Argentina, Tucumán, from Dr. Celati Francisco. Good morning, Dr. Duque. Is a medication with the preparation of several drugs in a single doses to treat sarcopenia in pharmaceutical industry?
Well, thank you for the question. And really, there is no at this moment, there is no pharmacological treatment for sarcopenia, sorry. So we tried, we actually participated in a couple of clinical trials to develop new drugs for sarcopenia. And probably at that time, 3 or 4 years ago, the most promising pharmacological intervention were the anti-myostatin antibodies, and it didn't work. It improved a little bit the muscle function, but a little bit the body composition, but it didn't really work on sarcopenia. So at this moment, we don't have a drug that could have an impact on sarcopenia specifically. However, we know there is new evidence that's interesting. From the perspective of osteosarcopenia, I'm sure you are familiar with denosumab, which is a drug that we use every 6 months for osteoporosis. There is an interesting set of new evidence showing that denosumab also has an impact on muscle function. We published some pilot studies. There's another interesting study from Switzerland showing that people treated with denosumab improved their muscle function. And the big studies, the big trials on denosumab show that denosumab reduced the number of falls. So it seems that RANK ligand, which is the target of denosumab, which is actually a very much a bone protein, could also have an impact on bone and muscle function. And this comes back to the subject of my talk about gerosines. One mechanism, in this case, RANK ligand, that has an impact on both diseases, on bone and osteoporosis and sarcopenia.
Okay, and now a question from Fontemaki Natalia. Hello, speech therapy treatment in presbyphagia that is often accompanied by sarcopenia. Do you see more boarding?
More
boarding. I don't know exactly if they say it's this a mistake.
Well, I can tell you about I can tell you about the presbyphagia and how it relates with sarcopenia. Definitely it does. And you know, we have become very interested on this topic together with a group from from Norway, where Miguel Borda, who is a geriatrician from Colombia, a young geriatrician, who is now working on it in people with dementia. What is interesting that we have been able to measure the muscle mass in the masseter muscle and correlate it with alterations in swallowing, and also alterations with the muscle mass in the tongue. We have been able to correlate it with the level of cognition and also as a predictor of functional impairment, in dementia. So yes, I think that this connection, that would be a very interesting study, is to look whether when you improve dysphagia in these patients, sarcopenia, you also prevent dysphagia. I'm not aware of any study looking at it at this moment.
Okay, thank you very much. Well, it's time. It was a great session. First to see you again. Your topic, it was wonderful. It was amazing. Well, thank you for all of us to participate here. Okay. Bye-bye, and see you again soon.
Thank you.
Bye-bye.